In this presentation, I'm going to talk about primary palliative care in the setting of liver failure. Just to define liver failure, it is a acute liver failure is characterized by severe hepatic parenchymal loss with the sequelae that comes from liver damage, which is coagulopathy, encephalopathy, decreased mental function, and eventually multi-system organ failure due to a systemic inflammatory response. It's the 12th leading cause of death in the United States. Generally, end-stage or acute liver failure is seen in people that have decompensated cirrhosis. You can also have acute or what's called fulminant liver failure. Generally, patients have cirrhosis, and the main three causes of cirrhosis are hepatitis B, hepatitis C, and alcohol use. The pathophysiology and etiology of it, again, generally what you're seeing is acute on chronic liver failure. So the patient has an underlying chronic liver disease, and there is some kind of insult to the liver that then creates this acute liver failure. This is described as the PIRO model by Biasco and Alguero, and it's a predisposition, insult, response, and organ failure. So what that means is basically you have a patient who's predisposed to some kind of chronic liver disease, so they're predisposed to acute liver failure as a result of this chronic liver failure. Generally speaking, in the Western countries, 50 to 70% of all underlying chronic liver diseases is due to alcohol cirrhosis. And then in Eastern countries, it's more due to hepatitis B infection, with that being 70% of the causes, and then 15% is caused by alcohol use. So you have this patient with a predisposition to liver failure, and then they get an insult to the liver. In 25% of the cases, this involves in active alcoholic getting an insult to the liver due to increased drinking. You can also have reactivation of the hepatitis or C virus viral infection. And then some patients have a bacterial infection, such as spontaneous bacterial peritonitis or a pneumonia. So now we have this insult to the liver, whether it be from too much drinking or from a reactivation or some kind of infection. And then your body has a host response to this insult, and the acute injury leads to further destruction of hepatocytes due to the release of tumor necrosis factors, cytokines, interleukins, and then this is through factor-induced apoptosis. The response is kind of similar to SIRS in that many organ systems can be involved. So it starts in the liver, and can kind of this inflammatory response spreads out to other organs, leading to multi-system organ failure. And then generally the organs that are affected are your adrenals, your hematologic system, your brain, heart, kidney, and lung. So management guidelines of acute and chronic liver failure is basically, it's very similar to managing any acutely or critically ill patient. They're spelled out pretty decently, and they go through body systems because these patients are generally in multi-system organ failure. Starting with the cardiovascular system, for resuscitation fluid, you would use albumin. Albumin is synthesized in the liver, so often these patients are hypoalbuminemic. Albumin acts as an antioxidant. It has immunoregulatory processes and endothelial regulatory functions. So it will help kind of immunoregulate and increase your intravascular volume. So if you have a patient who's dry, albumin is the resuscitation fluid of choice. The goal is to keep a MAP greater than 65. And that is generally just to keep proper coronary, renal, and cerebrovascular perfusion. They do recommend inserting an A-line in these patients, especially in a shock state, as the blood pressure cuffs may be inaccurate, and you do really need to keep kind of a beat-to-beat look on blood pressure and really keep an eye on it. For vasopressor support, if that is required, norepi is considered the first-line vasopressor. Studies show that norepi is more effective than dopamine in reversing hypotension. If you were to need a secondary Vasopressor, they recommend using vasopressin because studies show that it is the most effective pressor secondary to catecholamines and actually reduces the need for catecholamines. Hematologically wise, the threshold for transfusing a patient should be a hemoglobin around less than 7. In a study, they showed that maintaining a hemoglobin greater than 9 was associated with more transfusions, which then was associated with more transfusion reactions and adverse outcomes, without much benefit being shown between having a hemoglobin of 9 versus a hemoglobin of 7. VTE treatment and prophylaxis, these patients are have an increased risk of thromboembolic disease, including portal vein thrombosis. And study shows that the recanalization of the portal vein was greatly increased by using low molecular weight heparins over a year in patients that did have portal vein thrombosis. And for that same reason, that is what they recommend is low molecular weight heparin for VTE prophylaxis too, just to prevent any kind of thromboembolism. As far as pulmonary, as far as intubation is concerned, they recommend using low tidal volumes to prevent any kind of further barotrauma or volutrauma to the alveoli, which then would lead to an additional inflammatory response and cytokine release, which could further progress that multi-system organ failure. They recommend high PEEP, basically as an ARDS recommendation with no real specific addressing of high PEEP related to anything that has to do with liver function. It's really just ARDS recommendations in that. They do recommend a tube thoracostomy for patients that have a hepatic hydrothorax, especially in patients that can't undergo a TIPS procedure. It helps prevent the pain from getting these hydrothoraces, and also has been shown to actually close pleurodesis in about 50% of the patients that had these spontaneous hydrothoraces once they had the tube thoracostomy put in. They recommend before a patient is intubated, if you're going between high flow nasal cannula and non-invasive positive pressure ventilation, such as CPAP or BiPAP, they recommend using high flow nasal cannula, especially if you have an encephalopathic patient. They may not tolerate the mask and may be uncomfortable, and there really hasn't been shown any difference. There's been no difference shown in the intubation rates of patients being used between using high flow nasal cannula and the non-invasive positive pressure ventilation. However, if a patient is hypercarbic, it may recommend using the mask instead of the high flow nasal cannula. Renal recommendations is to use renal replacement therapy early in patients with the acute kidney injury, and that really helps reduce cerebral edema. They do recommend using vasopressors over not using vasopressors in critically ill patients with hepatorenal syndrome. And as far as the TIPS procedure for prevention of hepatorenal syndrome, there's insufficient evidence for doing that. And again, the TIPS procedure does increase the risk for hepatic encephalopathy. The goals for endocrine and nutrition is a target glucose of 110 to 180. They do recommend if a patient's in shock with liver failure to use stress dose glucocorticoids. Protein goals should be comparable with critically ill patients because initially, the thought is that you would use less protein to reduce the need for the liver to process that process those proteins. But decreased protein means increased carbohydrate use, which means gluconeogenesis by the liver, which is going to increase your ammonia anyway. So they really recommend keeping protein goals comparable to that with critically ill patients that don't have liver failure. They recommend feeding the gut as opposed to using TPN. As with most patients, it's better to feed the gut if you can. And they do recommend screening for drug-induced causes of liver failure and stopping those medications. as well as adjusting the doses of medications that undergo hepatic metabolism because they will be more potent. So palliative care, what is the role of palliative care in liver failure? These patients suffer from many symptoms. They have these underlying chronic liver disease that, barring liver transplant, um, they're going to have to establish goals of care. They're going to have pain symptom management, and that's really the purpose of palliative care and in these patients. And it's important to establish goals of care, especially if a patient's not encephalopathic, with the um, very real possibility that they will become encephalopathic. So setting goals of care while the patient is able to decide what they would want to do, how far they would want to go. And the one study about specialty palliative care has shown this was in patients that were getting towards end stage. They were probably going to die within 3 months. It was associated with fewer hospital readmissions, lower use of life-sustaining treatments that were only going to prolong life, not really add any quality to it, greater reduction in healthcare utilization, and higher rates of advanced care planning. And I think the higher rates of advanced care planning is really the crux of that, is making sure that the patient is able to make decisions when they're able to make decisions, or establishing just what the patient would want. It's kind of where palliative care fits into acute on chronic liver failure.